want to welcome everyone to the Designing Impact podcast. My name is Scott Haack. I am the Executive Global R&D Director at Microtech. At Microtech, innovation doesn't start with just an idea. It starts with intent. And the intent runs through every level of the company, every conversation, and every device that makes a difference. We're moving therapeutic innovation in endoscopy forward. I want to say I travel all over the world. I've met some of the biggest names in GI endoscopy, and I typically ask, who do you feel is the best endoscopist in the world? And more often than not, the name that is mentioned is Greg Haber. So it's an honor and a privilege to welcome Greg Haber to the Designing Impact podcast.
Thanks very much, Scott. I very much appreciate that. And I'm happy I've been able to make an impact over the years. It's more, it's the giving that is satisfactory more than anything else. And I think
absolutely.
That's true of so many of us in the field.
So right. I got to start with this. So what did it mean to you to win the prestigious Schindler Award this year? I mean, did you think, and I have to add this, did you think, I'm Greg Haber, it's about time? What took you guys so long?
Yeah. No, it's interesting because I've attended the Crystal Awards for so many years. And several years ago, I was awarded the Master of Endoscopy. And for me, that was kind of the apex of my career. I mean, I cherish that award in the sense that, endoscopy is my passion, my focus. And to be designated as master, I mean, I was done for my career. I didn't need more than that. But of course, the key award every year was the Schindler Award. And listen, the people who have won this have been kind of my heroes in a way, my mentors, some of them contemporaries, more like colleagues. But I never looked at it as something like, wow, why am I not getting the Schindler Award? I realize there are so many talented people in our field. There really are. And God knows, you just have to have the right intersection of people, the time of your career, whatever it is. I consider it, of course, I feel that, I've put my time in. I think I've taught many, many wonderful endoscopists. And so I'm proud to receive it. But on the other hand, I feel in any given year, there are a dozen other guys who would be equally worthy. And I say that honestly, it's not a false humility, but I do consider myself fortunate to have won this award. I have to say, I guess the key thing for me, it doesn't really change my practice or my love of endoscopy. It leaves a legacy for my family, number one, but the people I've taught and mentored over the years, I think it's a legacy for them too. So it kind of, it's a bright light that shines on everybody.
Absolutely. Yeah, for me too. And I tell you, I've known you for a while, but I still run into people that I didn't know that when they were training under you, and they say, I trained under Greg Haber. And I'm like, oh, wow, I did not know that. It's just the level of training and the talent that exists in the individuals, the physicians that are out there that trained under you is pretty vast.
That's the joy of being a teacher or a mentor. I mean, you plant a seed, and those seeds grow in many different ways in many different jurisdictions. And so over the years, of course, I started in Toronto,
right.
And my inspiration was Norm Marcon. Norm was an innovator himself. Norm always, whatever he was doing, there was a glint in his eye that he was looking to the future, something beyond what he was doing. He was kind of half in this world and half in kind of a dream world of something else going on. So,
love that. Yeah.
I caught a little bit of that from him, and it was a great start in Toronto. We just had a great group.
And you mentioned that whole dream factor with Dr. Marcon, and innovation comes in many forms. It can be a device, it can be a process, it can even be a procedure. How would you define a truly innovative product? And if you could touch a little bit on the process which made you invent the Haber ramp catheter, that would be advantageous as well.
To use the old expression, necessity is the mother of invention. That really applied to a lot of what was going on in the early days of endoscopy, because in the early days we didn't have many of the sophisticated accessories we have now. Certainly AI and robotics were just some dream way in the future, but even simple products that we have now were not available in those early days. So, for instance, the Haber ramp, that came out of a challenge of dealing with hilar strictures in the liver. Now, one of the innovative procedures early on, of course, was ERCP, and endoscopic drainage of malignant obstruction was a very hot topic. It was very challenging because of the anatomy of the hilum of the liver, the difficulty draining multiple segments, the risks of infection. So in those days, and there were many randomized controlled trials about what you have to drain. Do you have to drain the whole liver or part of the liver? So taking that, there were many times I would be doing an ERCP, and you clearly could, map out what you wanted to drain. In the early days, we didn't have MRI, but just on cholangiography, we knew what we wanted to drain. But you couldn't get there. You couldn't get a wire. You couldn't get up there. You just couldn't create a track in order to put a drain in that part of the liver. And so that led to the whole sort of review of what were our available techniques to do that, to get wires to go where we wanted them to go. Angled wires, straight wires, floppy wires. In the day, there was even a wire that had a mandrel. You probably remember this, in the middle of it, so that mandrel could control how much of the tip was floppy or not floppy. Because if the mandrel was stiff, if you pushed it right to the tip, it became a very stiff wire. If you pulled it back, floppy, etc. So it gave you one more way to manipulate the wire, along with the vice grip and rotation. But in spite of all of that, and we bounced wires off of balloons, and we used steerable tips, steerable catheters, etc. But one of the other ways that seemed to me would work well would be to kind of deflect the wire, not coming straight out from the tip, but deflect it to one side or the other. And so, because the left duct of the liver often took off at almost a right angle, it was difficult to get a wire coming straight out of the tip to turn right, if you like. They don't listen to you, those wires. I don't know why.
No, especially at that distance. They can't hear you at that distance. Yeah,
that's right. That's right. In any event, around that time, there was a product that Doug Howell had developed for multiple tissue sampling using biopsy forceps and brushes, etc. And part of that device was a small piece of metal that deflected, whatever you were putting through the catheter to the side. So that was kind of the basic piece of equipment or product that I thought would work with what I wanted to do. So I used that little deflector, and I created or asked Cook at the time to create the device, which would use a couple of these deflectors, one to one side, one to the other, because you didn't know when the catheter went in there where the wire would end up or where the catheter would end up. So 2 deflectors gave you the option of going one side or the other, depending on where the catheter was. So,
and what year was that?
I think late 90s, yeah.
Wow.
So, and it's interesting because it is a very niche product. And even today, I don't use it much because we have better ways or easier ways to deflect wires or get where we want to go sometimes. But still, in those situations where you really can't get where you want to go, and that is the device that will get you there. It was used actually in Asia a lot. Uh, when it first came out, I think more product was sold in Asia than in the West. Because,
Interesting.
So
And the invention of the VisiGlide wire probably helped you get into more areas a little bit easier versus other wires that were invented prior to that.
right, but certainly having that floppy tip and different degrees of stiffness to the shaft and ability to rotate. I mean, all of those things help.
Yeah,
And
torqueable wires are big, right?
yeah, definitely.
What do you think is the most innovative product in the past 5 and then 15 and 25?
Hmm. Well, listen, I think 25 years ago, there was, I would say there's no question in my mind that the sphincterotome, and maybe that goes back even 35 years, was perhaps the most innovative product that we had or that came along. Because I mean, it's hard to think back in those days when sphincterotomy was like the wow, being able to open up the bile duct. I mean, that's really where therapeutic endoscopy began in a sense. I mean, it was there before, but that was the most, I would think, impactful change at that time because there was no other way to treat common bile duct stones. And originally when Nipsohendra and Meinhard Clausen, when they developed those devices, they were revolutionary. It spread like wildfire. Every company wanted to make them. It was clearly kind of the hottest product around. So that would be, I think, and then there were many more iterations after that, of course, in terms of stone removal baskets and balloons, and it's interesting. All of those things they're not revolutionary in a sense. They're not crazy. It was just being able to miniaturize them, to take the idea and to make it work.
Yeah.
The execution, I think, was more challenging than actually the concept.
Absolutely. Yes. Working at that length.
Yeah. Going through a flexible scope, a tip, being able to maneuver it, developing the elevator concept, all of those things, which are routine today, 25, 35 years ago, were innovative, very innovative,
So in more recent times, what would you say is probably the most innovative product you've seen within the last, let's say, 10 years?
Yeah. Well, I'm going to do a hats off to Ken Binmiller because I do think the lumen opposing metal stent in therapeutics has been just a wonderfully executed or engineered device, if you like. And there's so many ways that we use that now. It's evolved from being a way to access, necrosis, retroperitoneal necrosis now, to being used for all kinds of luminal anastomoses, if you like. So
absolutely,
I think that has been, kind of a wonderful product. And,
yeah, absolutely.
And in my mind, it's interesting. It's very simple, simple in concept. It's a dog bone, right? You've got one one part.
I call it a dumbbell. I call it a dumbbell. I call it a dumbbell, but
yeah, dumbbell dog. But to actually engineer that and to get it through a scope and to control it and all that. So,
right.
I mean, there are many choices, but I think that was it sort of changed our whole concept of stenting.
Absolutely, yeah, and those are good choices. And I've seen the sphincterotome in your hands, and I don't think anyone gives a more generous sphincterotomy to expose that duct more than you or better than you. So that's it's been a workable device that has helped many patients in your hands, no doubt about it. I've seen it. So recently you lectured at DDW on the Lesion Hunter snare that we came out with, the new Edge Hog snare, the flat wire monofilament snare, and also a snare called the Advantis that's just launching now that coincides with a study that you completed with Dr. Doug Rex comparing APC to snare tip soft coagulation. Can you tell us about your findings in that study and the value of those results?
For over a decade now, and this is really spearheaded by Michael Burke and his the ACE group, the Australian Colonoscopy. I don't know what the E was, don't remember. Anyway, the group that he put together to study our techniques of colonoscopy and why were we getting recurrence and residual polyps in follow-up. And there have been many endeavors to reduce the recurrence rate. The optical side of it, where you look carefully, make sure you have it all. Injection of blue dye so you can see the margins. Taking a 5 millimeter margin, going wide on the lesion. All kinds of different things have been attempted, but the latest, I guess, in the last 5 years or so, initially introduced by Michael, was the snare tip soft coagulation method. So Michael's a very pragmatic guy, very, very straightforward, doesn't like to waste time. So if he had a polyp and he saw something on the edge, he said, just take the snare tip and burn the thing. Or something's bleeding, just take the snare tip. Don't use a coag grasper or, whatever else you're using, to coagulate. So from all of that came the concept, probably a lot of recurrence is microscopic adenomatous neoplastic cells you don't see, so just burn the whole margin. And, that triggered the RCT, which proved that burning the margin reduced the recurrence rates. And then out of that came the idea that, discussions among many of us, but Doug Rex, put together that pivotal trial looking at different ways to burn the margin. Could you burn it with a snare tip or an APC? But we wanted to compare APC versus snare tip soft coag. And versus nothing. And sure enough, if you treat the margins, you have reduced recurrence rate. I mean, really the ultimate question though becomes, that even if the recurrence rate is 3, 4, 5%, have you reduced it enough that you don't, that you've eliminated the follow-up at 6 months to a year? So, because when you do go, if you're going back in 6 months to a year routinely for large lesions over 2 centimeters, whatever's left is very easy to treat and manage. And Michael Burke actually showed that in his study. So it's a question of, is it worth the effort to, get rid of a certain percentage of recurrences if you're going back anyway, and what's there is darn simple. So I think the jury is out on whether this should become standard of care. Although the societies have jumped on it and they think, we should make this standard of care for large lesions. I personally am not there, but I think I think it's still, it allows us to recognize the importance of treating margins. So going back to different devices that you've been developing. Certainly simplifying matters by having a snare where the tip is modified to make coagulation easier, is great. I always think simple is best in engineering and development and everything else. And so and that's, something that you've done. You've changed the tip of the snare to allow that to coagulate easily, on the margins without changing your device, which I think is important.
Correct. To be able to concentrate that energy at the tip where you're using that usable end to actually get the results that you want, instead of having that widespread thermal injury, that you're able to control it. And that's the main impetus behind the Advantis snare. So yeah, absolutely.
And the other thing I'll mention is that when I say I'm not 100% behind, and I'm not, using snare tip or APC coagulation of the margins. It's that I think for most endoscopists, they're busy doing things. They don't really pay attention to necessarily what that snare tip is. See, Michael's study was done with a braided snare tip with a thicker wire. So the dissemination of the current was much broader. And I've seen people use other snares, which fewer braids, different conduction of the current, etc. And boy, they put it on I've seen this in courses, that it just doesn't work. They're not getting the effect. They're turning up the power because the snare tip soft coag is quite variable. Depends on the snare you're using. And you've got to adjust your current according to the wire, the number of braids, the thickness of the braids, all of those impact on it. So it's always when you get granular, as they say on these things, when you really drill down to how you get that current in there, how you execute, that is as important as saying, "Oh, I've got this snare tip."
Yeah, very good point. If you just want a dot instead of getting that widespread of thermal injury, if you just want to dot the area, you can do it, which is very good for marking. We talk about snare tip soft coagulation, but there's also an element of just being able to mark effectively around the lesion that you want to resect.
And listen, I'm a great fan of the Lesion Hunter. By the way, I hate that name. I love you.
Thanks a lot.
I love you.
Yeah.
I don't like
I came up with that name.
I know you did.
You're killing me, man.
Hate is too strong. I don't hate it, but I feel like I'm on an African safari. But joking aside, I just think the design of that snare is exceptional because it incorporates every single function you want in a cold snare. And, it's got the cheese cutter, the thin wire, the 018, so it's got the thinness to cut through. It has the rotatability, which is extremely helpful. And then it has the counter force of pulling against a metal tip as opposed to a plastic catheter as you cut through. What surprised me is that it seems to be soft, like with the nitinol wire, but it lays beautifully against the tissue. But don't ask me why. That's not something I would have thought would have been the advantage of nitinol. I mean, it has other advantages, but to me, it was a little bit counterintuitive, but a soft floppy would still sort of lay down on the tissue.
That's a very good point from the standpoint that when you feel it outside of the body, it feels very floppy, but it acts stiffer during the procedure than what you would perceive it to. And also braided cold snare wires deform over a certain amount of cuts. It keeps its shape, so you can do multiple cuts.
Yeah, no, it's beautiful. And now, now that we've expanded to doing much larger, especially SSLs in the right colon, much larger polyps, we'll use that same snare. We might cut, 7, 8, 9, 10 pieces to remove a 6 centimeter lesion.
So what is the largest lesion you've ever taken on block with the Lesion Hunter?
On block, I would say I've moved away from like the idea that I have to get it on block.
Mm-hmm.
And I'll expand on that a little bit. But the largest lesion I would remove on block with one cut is probably about 15 millimeters largest. I don't use the larger 15 or 20 millimeter Lesion Hunter. I feel that it's called 10, but that's the diameter. The length is, you can remind me, 13 millimeters, 14, something.
Yep.
So, you actually get more than a 10 millimeter lesion with it in a way. But I find that the protrusion defect that you leave behind is much greater if you have a larger snare, if you try to get it on block. And you can't necessarily cut it just with straight closure. You have to use forceful amputation by pulling it against the scope. Still works, the wire holds, etc. But I think, everything about endoscopy is having control. You want to know exactly what will happen when you do something and understand that. And for me, with the 10, I can get a wide margin. I mean, the trick is you inject a blue solution because the SSLs are very hard to detect that margin. And it's not a smooth arc of a margin. It's often kind of a zigzag margin, if you like. So anyway, I think you're better off focusing on margins, getting a good clean margin, and then continuing around and through the center of the lesion to make sure that you have it completely removed. I think that's better than trying to get it on block, which is very tricky.
Yeah, it's good advice. And sticking with polypectomy, and I know you've been a staunch advocate of avulsion technique over the years, and we even worked together on a purpose-built forceps for that particular procedure. So, for people that don't know, avulsion technique is a method of removing tissue involving a combination of mechanical force and thermal energy. So you highlighted the need for a purpose-built forceps before. Do you still think this is a viable technique which warrants a purpose-built device for this procedure?
I think that we can make improvements with a purpose-built device compared to the hot biopsy forceps that we use now. But sort of going back, a decade or so or more, I think hot avulsion to me, you talk about what has revolutionized, endoscopy. I don't want to brag too much, but I think hot avulsion really has revolutionized polypectomy. And the reason I say that is that every person out there doing colonoscopy, when they go back and look at the defect, they see something there that they missed or that didn't get trapped. Now, it might only be 2 or 3 millimeters, 4 millimeters, whatever it is, but it doesn't lend itself to snaring. You can't get it with a cold snare. You can't get it with a hot snare. We haven't talked edge hog, histolock. We can talk about other snares, but they're all almost way too big for something that's 2 or 3 millimeters or 4 millimeters. And they don't trap it that well. And if there's fibrosis, which is the reason why there's often a little bit of tissue left behind, it's tethered down, it's fibrotic, whatever. So the whole, there's no snare, let me put it that way, that can grab it as such. So back in the days when we had just given up on hot biopsy forceps that were used for diminutive polyps, what we now snare off routinely with a cold snare, 15, 20 years ago, people would use a hot biopsy forceps to grab it. Now, the reason that was given up and abandoned was because there was the post-polypectomy syndrome, which was a transmural burn, which led to pain or, in the worst case scenario, perforation. So, ASG guidelines came out, whatever it was, 15, this should not be used for diminutive polyps. And it was true. So, however, it was still valid for removing small bits of tissue. But again, with a different approach is what I'm happy to say I introduced was the use of a mechanical force and instead of a coagulation current, that's why it was called a coagulation forceps. We went to a cutting current, short bursts of a cutting current so that you wouldn't get dissemination, a thermal effect down through the muscle into the serosa. So we don't want the thermal effect, we want cutting. So the mechanical force, importance of that is that you tether the tissue. So you grab what you want to remove, then you pull it away from the base of the tissue. So what does that do? That kind of aligns the tissue that's going to conduct the current. And instead of having a wide area, it's a very thin area. So then it's thin, monopolar current, and you know this more than anybody. That's going to increase the current density tremendously, so you get the cutting effect. So basically, the forceps allows you to grab what you want, and then pulling away from the actual base of the lesion that you're cutting and using a short burst of high energy, that will then cut it rather than allow dissemination of current, which gives you the negative side of it. And that has been incredible. There isn't a fellow that we haven't trained who doesn't use it routinely in their practices. And now people talk about hot avulsion, and my biggest regret is that we haven't published enough on it. And in contradistinction to snare tip soft coag, that's meant for basically invisible, occult residual neoplasia, if I can put it that way. The hot avulsion is for what you see. It's for visible residual neoplasia. So overt, if you like. So, and the other thing that we always do with large lesions, we use near focus or magnification. We carefully, meticulously go around and look at the margins. And when we do that, I would say about half of what's residual was not clearly obvious to us until we took a careful look. And then we identify it, then we remove it. And one thing we have done, we did look back at 240 hot avulsion cases, and we looked at our recurrence rate, which was 4.8%, which is very low for recurrence for a huge, and most of our referral polyps are huge and, bound down, tethered down, whatever, but it's a very acceptable, relatively low recurrence rate, not 1 or 2%, but 4.8%. And a lot of those recurrences may occur from what's left, not at the margins, but in the center of the lesion, where you can tend to get more tethering, if you like, in the center. And there are studies about that too. But I think hot avulsion has become an essential tool. I would never approach a large polyp without having that available, or we use it kind of, I would say, probably 25% of the time with difficult polyps.
So before we conclude today, I want to ask an EUS question. Is there a correlation of the number of needle sticks or passes into the pancreas that leads to a higher risk of post-procedural pancreatitis? Have you seen that?
Post-procedure pancreatitis is certainly a concern, but the majority of cases where we are performing a needle stick, it's in malignant lesions in the pancreas. And so, fortunately, with malignancy, the chance of pancreatitis after a needle stick is much less. But if you're going into a healthy pancreas, or if you have to go through a large amount of healthy pancreas to get to the lesion, then your risk of pancreatitis is going to go up considerably. And so I think, and then you want to minimize the number of sticks for sure, because you don't want to be going through healthy pancreas, more than once to get to a lesion. And then it adds to the theoretic issue of seeding of tumor along the needle tract. If you're going into malignancy and then going back and forth, seeding, although it's rare, it's still there. It can occur, Sure. In fact, I remember I was at a EUS meeting about 9 months ago, and one of the mavens of EUS, of course, is Anand Sahai. And he was telling me he had a case, in his personal experience, he had a case of seeding that was well proven. So it's not zero. I mean, it's a small risk, but I mean, if you're the person who has the cancer, it's a massive risk.
I was just going to add that, if it's not zero, there's a chance that you could fall into that 1, 2, or 3%.
Yeah. And in fact, and I think it's still true today that in Asia, they were very much against FNA proof or FNB sampling of lesions if in every other respect you felt it required surgery or was a cancer. I mean, if the CA19-9 was 800 and it had all the features of a cancer, they often would not needle put a needle into that for fear of creating a track, seeding along the track.
And they would just go right to surgery then.
Yeah, right to surgery, or even neoadjuvant chemotherapy without tissue.
Got it. So do you feel, I mean, based on that, do you feel there is a definite need for an EUS FNB needle that is truly a one stick needle?
Listen, I think it all depends on how good it is at getting that tissue.
Right.
So, but one stick and adequate tissue, sure, it's better than 3 or 4 times, and uh, and the sort of on-site evaluation. I think most people have almost stopped using that, but they just examine the tissue they've got in the formalin,
Correct.
And they say, okay, we have enough. That's what we do at NYU. Almost 5 of us who do or 4 of us who do all the FNBs. We rarely do FNA anymore for solid lesions. It's almost all FNB, and we don't use rapid on-site evaluation. And I think we have about 98% or 95% positive result.
Yeah. So what do you feel is the biggest unmet need in endoscopy at this stage of the game? With all of the new technology that's out there, what is still the biggest unmet need in endoscopy?
That is a very good question. But I think there are 2 areas where we've made some advances, where we could make more advances. I think maybe the one area that would impact a lot of endoscopy would be articulation. In other words, every device that you put down through the channel to operate on or to do some operative procedure, it usually has a function of up or down, one way or the other. You can't really angulate it, or you have a swivel tip on a biopsy forceps, but you can't take the forceps and turn it down, turn it up, turn it left, turn it right. So when I say articulation, the ability to take that device, whether it's scissors, coagulation, whatever it is, and turn it, 30 degrees one way, 80 degrees, whatever it is, the type of the way you control the tip of a scope. If we could control the tip of a device that way, it would help a lot. Any cutting device, coagulation device, that sort of thing. And that's, of course, the world of laparoscopy is built on that. It's built on just you take it and you can turn it every which way you want. Now, if you could do that in a flexible way with a flexible device, that would be an enormous advance, I think. But again, it has to be made simple. You can't be too complicated. And then the other area, of course, is closure, and it's suturing. And of course, right now we have Apollo as kind of the workhorse for endoscopic suturing. But for those of us who do it on a regular basis, it's still a little bit cumbersome. It can be challenging at times, and so we need better suturing. Certainly, that will be an advantage, just to be able to go, straight down, grab it, have automated throw of the suture through the tissue, boom, 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 could be done quickly. And then we'll see much more in the way of full thickness resections and less fear for getting an RO resection vertically when you're worried about perforation,
And I want you to comment a little bit about this. There we go. Can you see that?
I do see that.
Okay. So as I said, and this might be a couple years ago now, or maybe a year and a half ago, but as I said previously, innovation comes in many forms, and it can be a device, it can be a process, it can be a procedure. And on this particular day, this patient made a life-saving decision to see you. Before the invention of ESD, this is a hemicolectomy. And his life is a lot different yesterday than it is today. By seeing you on that day, his life is the same today as it was yesterday. So this is absolutely amazing. An on-block resection of over 16 centimeters in length with ESD utilizing devices in the hands of you, Greg Haber. Can you run us through this particular case a little bit?
Sure. Well, listen, I haven't talked a lot about ESD, although I do think it's been one of the major revolutions in endoscopy over the last 20 years now, really. Um, and before I take you through this particular patient that I did, I have to say that, the Japanese really developed this technique, and several different centers in Japan were working on this, different tools. Every endoscopist had his own tool, his own device, and that sort of thing. And, I was fortunate because when we ran our meeting in Toronto, we would invite the Japanese to do these cases, to do an ESD. And in those days, which was the late 90s, we'd give them a case at 2 o'clock in the afternoon, and they would show up at the faculty dinner at around 9 o'clock at night. Never leaving the endoscopy suite, even though the course
Right.
ended at 5 or 6. They would still go at
Right.
it. So even the Japanese, when they started, would take several hours to do these things. They would do the same lesion today probably in 1/4 of the time,
Mm.
but because they have better instruments, better understanding, all kinds of different techniques. But the lesson is that when you start with a new technique, you have to take your time. You have to learn the skill set. You have to, obviously the accessories help a lot, but I recently heard a talk on ESD from one of the French mavens of ESD, who works out of probably one of their largest centers in France. And he said, he was wanting to give like the 10 tips for effective ESD and successful ESD. Number one was waste time. Waste time. In other words, what he's saying is, I don't know if the French translation didn't work out that well, saying waste time, but the idea was you can't rush, and success is not speed. Obviously we need efficiencies. We have to do it in a certain amount of time. But his point was that ESD is a meticulous procedure, and
Right.
over time you will get better and faster, and all, and we'll have whatever it is, traction and different devices, robotics, etc. When you're faced with a large lesion that needs resection, I think number one is make sure that you have allotted enough time. Don't rush yourself. Make sure that you have enough time to do it effectively. You want it on block, etc. And in certainly in the colon, in the rectum, the option of proctectomy is not a good option. So if it's within 3 or 4 centimeters of the anal verge, certainly the patient is faced with a terrible decision, because coloanal anastomosis is not pleasant to live with. Patients put up with a lot. Certainly, it can affect sexual function, and there are many downsides, to that resection. So I think in that situation, an ESD is life-changing for the patient. But the other good thing is the rectum is also maybe the easiest area to do ESD. So
Because it's thicker.
that fact, and the fact that it's very impactful for the patient, I think makes it a perfect place to start ESD if you're just starting out. And getting and sort of just these types of patients, we do a lot of ESD that where the polyp goes right down to the anal verge, or it's low rectum, and also higher up as well. But it's most impactful when you're saving a proctectomy, no question. These large lateral spreading tumors often have focus of high grade. They're pre-malignant. It's critical to get it out completely on block. The other thing I'll have to say, kind of as an aside, is I never understood in the early days when the Japanese would come to Toronto and they'd do an ESD, and everybody was in awe in those days. And then at the end of the procedure, after 4, 5, 6, 7, or 8 hours, they'd have this specimen. And I'd always say to them, well, we'll get the fellow to pin it out.
Right.
And they were absolutely, no, they have to pin it out themselves. And what I realized was that the metric for a good ESD is RO resection. You cannot have, every margin has to be negative. And
Right.
when you pin it out, there's an element to ensuring that what you hand to the pathologist is laid out in such a way that they can easily identify the normal mucosa adjacent to the lesion. So they spend a lot of time, making sure that all those margins are pinned so the normal mucosa is showing. So and ever since I started ESD, I pinned them all myself.
Yeah.
Yeah.
And I'll bring that back up again. And now you can really see the lesioned area and the healthy,
Here,
more healthy
I have to say,
tissue.
this went down to the anal vert, so you don't quite see as much of the normal, but
Healthy,
that's important.
Little bit over here, maybe on the.
Yeah, you can see it there and the other end. But
Yep.
and of course, when you do circumferential ESD in the esophagus, the edge that you cut, one edge will never be negative.
Right.
It's circumferential, yeah.
No, that's absolutely incredible. I remember when you showed me that, and it was, I was like, how long? First question, of course, is how long did that take you? I mean, that doesn't look like an hour-long procedure.
No, I don't remember. I'm sure it's 6 hours. I'm sure 5 or 6 hours at least. Yeah.
But
if I was smart, I should have said it doesn't matter.
No, and it really doesn't. And I tell you that patient's thanking.
In real life,
patient's thanking you. Yeah. That patient's thanking you today without physically or verbally thanking you. The fact that they're walking through life the way they are today, they're thanking you.
No, that's true. That's true. Yeah.
So let me conclude with this, because I know you got things to do today. I want to let you know, when you decide to call it a career, GI endoscopy will be losing a true superstar, a true giant and legend in the field. There are a lot of talented GI endoscopists, and we talked about that earlier, and a ton of great up and coming physicians in the field. And you will leave this field, this GI endoscopy field, better than when you found it. But there is only one you. There is only one Greg Haber. And I thank you so much for appearing on this podcast with me. It's truly an honor and a privilege, and I thank you so much.
Listen, I'm very grateful for those words. It's coming from a guy who works in the field day in and day out as well. It's very much appreciated. And let me turn it around a little bit and say, Scott, that we've worked together on a few projects in our day, and I have to say that in terms of collaboration, working with industry and individuals in industry who have the same objectives as the clinicians is critically important. And I've been very appreciative, and you've contributed enormously to the field of endoscopy and advanced endoscopy. And we, and me speaking for the clinical side, are forever grateful, because we could not do what we do without your ears listening to what we need and your hands executing. And for that, it just emphasizes that this collaboration is what drives us all forward in our field and ultimately helps the patients. So thank you.
Wow.
Thank you.
Well, that's something I was not expecting, but it hit me hard here. I thank you. Thank you so much for spending this time with us. And for everybody else, we'll see you next time on the Designing Impact podcast.